Okay, our last speaker is going to be speaking on an electrical storm is coming. The speaker is Dr. Munther Homoud, who's a colleague of mine, a close friend, and if I needed an EP doctor, God forbid, he'd be the one I would choose.
Thank you very much. I'd like to begin by thanking Dr. Marwan Jamian for inviting me, and Dr. Konstam for electing me 33 years ago to become one of his fellows. Otherwise, I wouldn't be standing before you in this podium. So I'll begin by speaking about electrical storm. How do I advance the slides? So the definition of electrical storm is the occurrence of 3 or more episodes of ventricular tachycardia within a span of 24 hours, as long as the episodes are separated 5 minutes apart from each other. And because a large number of these patients have defibrillators, we see that patients with secondary prevention defibrillators have a much higher incidence of suffering from electrical storm and at a sooner interval than patients with primary prevention defibrillators. The incidence of an electrical storm in patients with ischemic and non-ischemic cardiomyopathies is quite similar, and patients who have CRT devices have a lower incidence of electrical storm, largely because their ejection fraction tends to be better than other patients. It's very important to document the arrhythmia at the time of the storm. Patients with monomorphic ventricular tachycardia indicate that they have some scars, so structural heart disease, compared to patients with polymorphic ventricular tachycardia and ventricular fibrillation, where ischemia and primary channelopathies is suspected to be the cause of the storm. An example here in the upper left panel, you see monomorphic ventricular tachycardia, where each QRS complex looks similar to its predecessor and successor. This is a reflection of the presence of scar. You see this in ischemic cardiomyopathies, some non-ischemic cardiomyopathies, arrhythmogenic or right ventricular cardiomyopathy. And the bottom right panel, you see polymorphic ventricular tachycardia, and one realizes and appreciates the depth of the T-wave inversion and the extent of the prolongation of the QT interval, a reflection of a long QT syndrome. The right upper channel shows you bidirectional ventricular tachycardia, seen in patients with catecholaminergic polymorphic ventricular tachycardia and rare cases of digoxin toxicities. The left lower panel shows you a type of polymorphic ventricular tachycardia that I will allude to in the end, precipitated by a shortly coupled stereotypical PVC. So needless to say, patients with an electrical storm compared to those with occasional ventricular tachycardia have a higher mortality, anywhere between a 2.5 higher mortality compared to patients with ventricular tachycardia and a 3.5-fold higher total mortality compared to patients with no ventricular tachycardia. Patients with an electrical storm have an up to 2-fold higher incidence of an acute myocardial infarction, target vessel revascularization, and total mortality compared to patients who have ventricular tachycardia but do not suffer from an electrical storm. There has to be a confluence of 3 factors to coexist for an electrical storm to take place. The first is the substrate, and the substrate can be structural, such as an ischemic and non-ischemic cardiomyopathy, or a channelopathy. The second factor is a trigger. The trigger can be things such as ischemia, electrolyte imbalance, medications. We strive to find a precipitating factor, but we rarely find it in more than 13% of the cases. And then the third factor is the perturbation of the autonomic nervous system, particularly the detrimental role the elevated sympathetic nervous system plays in precipitating and perpetuating an electrical storm. Most patients, of course, are symptomatic, but an electrical storm can incorporate patients who have ATP therapy for their ventricular tachycardia. So in rare cases, they can be asymptomatic. They can present with death. Most of them present somewhere in the middle. And the most common arrhythmia seen in an electrical storm is sustained monomorphic ventricular tachycardia. In patients with defibrillators who present with an electrical storm, and this is not an unusual set of circumstances, it's very important to determine the cause of the storm. The cause may be recurrent ventricular tachyarrhythmias, but it could also be inappropriate due to supraventricular tachyarrhythmias or problems with the lead itself, such as a fractured lead or what is known as electromagnetic interference, and I'll show you some examples of this. There is considerable debate about the role of coronary angiography in evaluating patients with an electrical storm. It used to be a routine that these patients would undergo coronary angiography. Now we really look for solid evidence of ischemia, such as ST segment elevation, a troponin elevation that exceeds what one would expect with the defibrillation alone before we take these patients to the cardiac cath lab, because more often than not, we do not find a culprit vessel that can explain what's happening to the patient. In rare cases, we have some targeted therapies, endomyocardial biopsy in patients we suspect have giant cell myocarditis, or doing the PET scan to rule out sarcoidosis, although treatment for sarcoidosis itself, directed towards sarcoidosis, rarely, if ever, eliminates the ventricular tachyarrhythmias. The management of the ventricular tachyarrhythmias in this scenario is just like the management of ventricular tachyarrhythmias in any other situation. These are examples of inappropriate shock. The left upper panel shows you a patient who has a dual chamber ICD, and as you can see, I don't have a pointer, but in the upper row, you can see the atrial lead showing you a patient with an atrial tachycardia. The ventricular lead shows you the rapid ventricular response, and then a shock terminating both the supraventricular arrhythmia and restoring sinus rhythm. So this is an example of an inappropriate inappropriate shock delivered for a supraventricular tachycardia. The bottom left panel shows you ATP being delivered in a patient with ventricular tachycardia. The dreaded scenario is the scenario you see in the right panel, where a patient has noise reflected in the high, the abnormality seen on the ventricular lead, the high frequency signals due to a fractured lead, where an inappropriate shock is delivered, and the inappropriate shock itself precipitates ventricular fibrillation. The management consists of basic ACLS protocol, withdrawal of offending agents once the agents are recognized, correction of electrolyte imbalances and abnormalities, management of heart failure. Heart failure is a trigger for an electrical storm. And then you look for possible etiologies to the electrical storm. If you suspect ischemic heart disease, then yes, cath the patient. In cases of giant cell myocarditis, as I mentioned earlier, endomyocardial biopsy and immunotherapy for those patients. Specifically in patients with Brugada syndrome, because pyrexia is a trigger, identifying pyrexia and treating pyrexia is an important component in alleviating the storm. In CPVT, there's a vicious cycle that occurs in CPVT, that the shocks in and of itself increase the sympathetic tone, and the sympathetic tone becomes a driver for further shocks in these patients, and that's important to realize. I mentioned the importance of interrogation of the defibrillator. As far as management goes, the two most important components in managing patients with electrical storm is sedation, preferably intubation. Propofol is a very effective antiarrhythmic agent. When we do these cases, when we do ablations for both SVTs and VTs, the use of propofol can confound the procedure because it inhibits both supraventricular and ventricular arrhythmias, and it's a very effective way of addressing electrical storms. Pharmacology, the pharmacotherapy remains the cornerstone of managing electrical storms. Specifically beta blockers and non-specific, non-beta selective beta blockers, as well as amiodarone. And many investigators believe that the effect of amiodarone in alleviating ventricular tachyarrhythmias is through its beta blocking effect. And then once you've identified an underlying cause, you can address the underlying cause, especially when you're dealing with channelopathies. Now, what is really pertinent to this kind of an audience is where the overlap is with using mechanical circulatory support in patients with an electrical storm. And this occurs in three contexts. The first is, what is the role of mechanical circulatory support in patients with electrical storm? And here the data is conflicting. There are some data showing that there is some advantage, others showing that there's no advantage in implementing mechanical circulatory support in patients with an electrical storm. The second scenario is when you're doing a VT ablation. When you do a VT ablation, there are two methodologies. You either target the arrhythmia itself activation timing, inducing the clinical VT, and trying to map it, find the circuit, and ablate it, versus substrate modification. You're looking at the potential causes of where the ventricular tachycardia is coming from using abnormal electrical signals, identifying scars, and targeting that. And there's advantages and disadvantages to both of them, but the big disadvantage of trying to identify the clinical VT and mapping the activation of the ventricular tachycardia is the incidence of precipitating cardiogenic shock. And this can be seen in as high as 13% of patients. And then you have to institute mechanical circulatory support, and here the outcomes are not very good. The outcomes of implementing mechanical circulatory support is best seen if you can anticipate in advance the patient who is likely to decompensate during the ventricular tachycardia ablation. And here we use a score known as the pain ESD score, which looks at these variables: ischemic heart disease, advanced heart failure, COPD, presentation with electrical storm, age over 60, ejection fraction of less than 25%, and diabetes mellitus. If the cumulative score exceeds 15, then there's a high incidence of these patients succumbing to cardiogenic shock, and mechanical circulatory support can best be instituted prophylactically before the patient undergoes ventricular tachycardia, usually in the form of ECMO. Oh yeah, I'm all done. And actually, that's as far as catheter ablation involves, usually after the first 48 hours of the patient presenting with electrical storm. Thank you very much. I'll be happy to take any questions you have.
A whirlwind overview. Comments or questions for Dr. Homoud?
Enjoyed your talk.
Thank you.
Given that inotropic therapy as a therapeutic modality for cardiogenic shock is also arrhythmogenic therapy, I wanted to find you and panel's input into what is your approach in your center, given that interventional EP in this setting is also particularly high risk. And insofar as a pain SD score that you mentioned, I can't think of the last time I had a patient with a pain SD score less than 15. Almost uniformly, anybody presenting with cardiogenic shock in our center, it's well above 15. So I wanted to get a flavor of the approach and how you stabilize your patients before
Well, I have
this
good
approach.
fortune of working at an institution which was really pioneered by Dr. Konstam. We have advanced therapies, and we have a low threshold of asking them to intervene in advance using ECMO in patients. We think there's a high likelihood of them having shock in the process of the procedure. And I and many of my colleagues, you really do substrate modification rather than trying to map the ventricular tachycardia specifically to avoid this complication. And I can never underestimate the role of the sympathetic nervous system. So yes, catecholamines and other drugs that can potentially increase the likelihood of ventricular arrhythmias, but that tends to surpass our concern for arrhythmias. We use a combination of pressors and amiodarone to suppress these arrhythmias.
Russell?
Yeah, so one of the populations that we find pretty tricky is the immediate post-op LVAD patient who develops persistent VT. And, we'll sedate them and give them antiarrhythmics and all these things. But unfortunately, the RV ends up tanking in the patients who are quite resistant. And so one of the things that eats at me is, what is the role of a RVAD temporarily earlier on, once you have a post-op LVAD patient in VT, and to support the RV until the VT can be controlled?
I would not be able to answer that question because that's not my field of specialty. But I'm very familiar with the concept because we tell the heart failure folks, look, the patient's fine, he's in VT, but no big deal. And they'll always come back and say, the RV's going to fail, you've got to get them out of VT. And that's what we do.
So, what's the approach in your institution? We constantly have a battle with our EP. So, patient with heart failure comes with ICD shocks. So, the chicken or the egg, is it the heart failure causing the VT, or is it the substrate per se scar causing the VT? And is it safe to do substrate modification? And what's the exit strategy? This keeps coming about. We douse everybody with amio. So, what is your institutional preference here? Do you upfront go for aggressive substrate modification, or?
Usually managing heart failure first.
Yeah.
I mean, that's going to be our, and then if the decision is made to bring the patients down for a VT ablation, it is going to be substrate modification.
Yeah. I think at our center, we definitely do a shock team approach. So somebody has a high pains D score, we will do upfront temporary MCS, and now we're doing a lot more Impella 5.5s beforehand, so we're not in a high afterload state with the ECMO, and then slowly wean them off in the cardiac ICU. If they have a borderline pains D score, then we'll put in placeholders. And then to your other question, if the patient has had long-standing heart failure, worsening heart failure, and then VT, we'll say that's a sick ventricle and maybe do VT ablation at the time of durable VAD or straight to transplant. But if they're doing great and their NYHA doing well, likely not decompensated and have primary VT, then we'll go for high-risk ablation.
So similar, just to weigh in to Joyce, I think a ventricular dysrhythmia, struggling heart on jet fuel, temporary support early, and what platform you use depending upon the profile. If it's extremist, we do VA ECMO, concomitant balloon pump for LV unloading. If we have time, Impella 5.5 tends to be very helpful. We're going to address the ablation opportunity, right, in the context of decision making, but it's all about stabilization. So my stance, or how we approach it, is early temporary support as opposed to continued pharmacologic challenges that just complicate the picture.
Comments on epicardial ablation, and second question is radiation therapy for refractory arrhythmias in spite of substrate modification. What's your thoughts on that?
So epicardial ablation, so there's a subset of patients in whom epicardial ablation is going to be necessary. Most of them are non-ischemic cardiomyopathies. In patients with non-ischemic cardiomyopathies, the scars are intramural, epicardial. The one subset of patients with ischemic cardiomyopathies who may have an epicardial exit site are patients with inferior wall myocardial infarction. There is a school of thought also that patients with Brugada, that there is some fibrosis in the epicardium at the right ventricular outflow tract. So there's two ways to anticipate who's going to require an epicardial ablation. First of all, who is the patient? What's the cause of the electrical storm or ventricular tachycardia? And second of all, if you can document, and documentation of the arrhythmia is very important. And there are clues on an ECG as to who's going to have an epicardial substrate and who's not going to have an epicardial substrate. So that was the first question. The second question was the
Role of radiation therapy when there is substrate modification failure.
Right. So I personally do not have any experience with this. Neither does my institution. There's one institution in Boston, which is the Brigham, that has that radiotherapy. I can't comment on it.
Okay. Last
We've
question.
covered ventricular arrhythmias in this population. What is your approach to refractory supraventricular arrhythmias in this setting of people with cardiogenic shock? This is often a problem that we deal with: recurrent atrial fibrillation, rapid ventricular response, inability to use certain rate-controlled medicines because of the clinical situation.
The struggle has always been in this situation is whether we're trying to restore sinus rhythm or try to get better rate control. Amiodarone has been pretty effective in achieving both goals. Sometimes using amiodarone as a rate controlling drug because it does not drop the blood pressure and it has marginal effect on hemodynamics. So that's our go-to drug when it comes to managing this very difficult subset of patients.
I've been waiting here very patiently.
If we could see you, we would have called on you. Go ahead.
Hi, Phil
Sorry.
Spilley from Toronto. So lots of challenging cases. I'm sure there's lots of us in the audience that have had patients, non-ischemic, whatever the etiology is. They're on VA ECMO. You get them off the rocket fuel, but they're in VT for days, incessant VT. And you know, our EP colleagues, God bless them, come by, say, oh, they're in VT, and then they walk away. Where we're thinking about recovery, amiodarone is doing nothing. The ICU is shocking the ventricle left, right, and center. At what point do you just say this is a sick ventricle and just let it be and see if we can just get them to transplant? Is shocking really even a viable option? How many times should you shock and stop shocking? It's an argument that I constantly have with our ICU folks.
So I mean, I haven't had the experience of, I mean, we have a transplant program, we have a VT ablation program, but I haven't had the experience of keeping somebody in ventricular tachycardia incessantly until they've had their transplant done. At some point or the other, we were able to get them back into sinus rhythm combination of amiodarone, defibrillation. And the one thing I also did not mention is neuromodulation by doing stellate ganglion ablation block, and we have a very low threshold for doing that. We've not done epidural, T4, C7T4 epidural anesthesia for these patients, but there are options to try to get them out of ventricular tachycardia.
Sometimes they don't work.
Then you have transplant, I guess.
Okay, it's past time. I want to thank all of the speakers for a terrific session and thank the panelists and the audience too. See you later, everybody.
Thank you. I believe they're going to announce the scavenger hunt and